Feeling blue?
Good.
Good.
Good. We are called to create an even better and more just world.
And this is Creighton's response.
Reach out beyond boundaries.
And differences.
To serve those with needs.
Greater than our own.
This is Creighton.
This is Creighton.
This is Creighton in the community.
Hello and welcome to this special edition of Creighton in the Community. I'm Joyce Bunger and I'm going to be your host and your tour guide today as we visit the Center for Digestive Disorders at Creighton University. I'm joined by Pam Doohan, who is the clinical coordinator and a nurse practitioner for the Center of Digestive Disorders. Tell me about the concept. What happens here?
The concept of the Center for Digestive Disorders is that patients can make, or physicians who are referring patients can make one phone call and we take it from there. So whatever specialties the patients need to see, we arrange that. Any diagnostic testing, we arrange that. It's a one-stop shop for both physicians and patients.
What types of physicians would someone come to the Center for Digestive Disorders?
We have several programs here. We have a nutrition and wellness program, and we also have an esophageal program. We have a gastroenterology program, and then we have a cancer service line program.
Let's get started. Let's go meet Dr. Upchurch.
Okay.
We offer some of the region's most advanced cardiac care. We're widely recognized for our cancer research. We train some of the region's brightest and most sought-after doctors and nurses. We offer a broad range of minimally invasive surgeries. And there's one thing we do that no other medical institution in the world can. We proudly bear the Creighton name. Creighton University Medical Center.
We're here at Creighton University's GI Lab, and I'm talking with the Chief of Gastroenterology, Dr. Benny Upchurch. First of all, why don't you tell me what gastroenterology is?
Well, gastroenterology is the study of digestive diseases.
And what are some of those that would be familiar to our listeners?
Well, commonly we think of peptic ulcer disease, gastroesophageal reflux, and of course colon polyps.
And let's talk about each one of those. What probably is the most common malady that people come to see you?
Well, gastroesophageal reflux disease is probably the most common. So many Americans suffer from heartburn or indigestion that actually represents gastroesophageal reflux disease.
How do you know if you have this?
Most people complain of heartburn or burning behind the chest here, and sometimes they in fact feel things regurgitate or come back up into the esophagus, maybe giving them a bitter taste to the mouth.
What causes this?
Well, acid is part of our digestive process, and sometimes as it comes back up into the esophagus, it can be uncomfortable. So it's a common process that we experience sometimes commonly without it necessarily representing the disease, acid reflux. But in individuals that have a lot of acid burning or indigestion, it may represent reflux disease.
I always pause before I ask this, but is this something that comes on with age? Is this something that I should be, what I'd be more inclined to get being over 50?
Well, it's not particularly worsened as we get older, but it may affect people of all ages. Sometimes there are other conditions.
Children?
Even children.
Really?
Yes, ma'am. The most significant problem is when people are on medications that may also worsen reflux, or as they gain weight, they're more likely to experience persistent heartburn or reflux symptoms.
What you're talking about, is this GERD?
Yes, ma'am, it is.
And GERD stands for?
Gastroesophageal reflux disease.
Okay, that's GERD. Because that's a term that I'm hearing more about is GERD. Can GERD be monitored by diet? Like is surgery an option for GERD, or is it managed some other way?
Well, surgery is certainly an option, but ideally we can start with things that are less invasive than surgery. As you mentioned, dietary manipulations may be helpful. For instance, trying to avoid things that are particularly spicy or acidic, not eating right before lying down. And of course, if you do have any extra weight to lose, then losing some weight will also sometimes help with reflux symptoms. But surgery is typically reserved for individuals who, despite medication and lifestyle adjustments, still have persistent heartburn symptoms.
Is the surgery on the stomach area or the esophagus, or where is?
Well, actually both.
Both?
The typical reflux surgery, in fact, helps to build a new valve at the lower part of the esophagus, and that's made by wrapping the stomach around the lower portion of the esophagus.
Wow. Wow. There were some other, you mentioned two other areas. One of them I remember is the disease of the bowel. Let's spend some time on that. I think I recently admitted to you that I haven't had a colonoscopy, and you chastised me a bit. Tell me why that's so important.
Well, colon cancer, particularly in the West, the U.S. in particular, is a common problem. And unfortunately, it could be almost entirely prevented with screening. So Americans, unfortunately, only about a third of us will seek out screening, meaning getting evaluated before we develop symptoms. So if we were able to get most individuals in for screening at around the age of 50, we'd be able to prevent almost 90% of the colon cancer out there.
What are the symptoms?
Well, most individuals that develop polyps, which are the precursor for colon cancer, have no symptoms. In fact, by the development of bleeding or an unexplained anemia or even an abdominal pain, generally that may be more suggestive that advanced disease or colon cancer is present. So ideally, we like to reach individuals before there's any symptoms.
You find that people hesitate coming to see the center because it deals with things that people aren't comfortable with?
Well, sure. And like almost any area of medicine, we hope that once an individual is here, that the staff and the physicians are able to make people more comfortable talking about their concerns.
And I have felt that as I walked in here this morning, that it's a very approachable office, and people are very kind here. There were two other areas that I wanted to ask you about. There's some, and I don't know if you call them, well, one is Crohn's disease and the other is Barrett's. And those are names that diseases that weren't familiar to me. Can you talk about both of those?
Sure. Well, first of all, Barrett's is a condition that's primarily found in individuals who have suffered from reflux, particularly those who have had acid reflux for years. So it's a chronic inflammation of the esophagus that is most significant because it may predispose to esophageal cancer. So fortunately, most individuals with reflux aren't going to develop Barrett's, and most individuals with Barrett's found are not going to develop esophageal cancer. But once we know about an individual having Barrett's, we do watch them a little more closely.
And Crohn's?
Crohn's disease is one of the inflammatory bowel diseases with ulcerative colitis that affects, again, many millions of Americans. It is managed very well with medication and, in some cases, surgery. So finding inflammatory bowel disease does lead us to appropriate therapies.
Do people, well, I'm going to rephrase this question. At what point should people make an appointment to see you? Should they try to, use Tums and try lifestyle changes before they come to you, or should they come to you right away?
Well, we use a number of 2 to 3 reflux episodes or severe heartburn episodes per week as a cutoff for most individuals. If people are having more persistent or frequent symptoms than that, we really suggest that they either speak with their primary care doctor or to, of course, see us as gastroenterologists. So anyone with any persistent type of gastrointestinal symptom probably should seek care.
Does it make sense to take the Tums and the Prilosec and those types of medications? Are those effective? What percent could be treated with lifestyle changes and medications before having the more dramatic procedures? Quite a few?
Quite a few, actually. And in fact, it's helpful for the doctor to understand what the patient's response was to those types of over-the-counter maneuvers and lifestyle modifications. But ultimately, still, if someone's symptoms persist or they come back immediately after stopping those types of agents, then we suggest that they be seen.
And I have one last question for you. If I have any of those conditions, if I have the acid reflux, do I go to my primary physician first, or do I come directly to you?
Well, in most cases, the primary care physician is where we would want people to start. And when there is the need for expert consultation or perhaps procedures, then as subspecialty physicians, we're typically asked to intervene.
Thank you so much for your time, and I'll be back.
Thank you.
And when we come back, we will visit about abdominal wall reconstruction in the stomach.
When you go to class at Creighton's College of Business, you will not be taught by a graduate student. but by a real professor. Our faculty members have received Fulbright fellowships, been named scholars in residence at the Securities and Exchange Commission and the Congressional Budget Office, and many sit on the boards and act as consultants for Fortune 500 companies. The bottom line, they bring a wealth of applied knowledge to their areas of expertise, and many are regularly quoted in Business Week, the New York Times, and the Wall Street Journal. This kind of real-world experience is highly prized in the College of Business. We take it so seriously that each semester, through our Real Returns program, over 100 business professionals join Creighton students in the classroom as guest professors.
I'm here with Dr. Robert Fitzgibbons. He is a surgeon at Creighton University Medical Center, and he's going to talk to us today about abdominal wall reconstruction. Good morning, but before I start, I want to congratulate you. You were recently named to one of 2010's Best Doctors, and that's quite an honor for you. How was that honor bestowed?
Well, thank you for that. Colleagues get together and make recommendations about various physicians in their area, and that's how that data is generated.
And your area is abdominal wall reconstruction
And general surgery.
General surgery. And are you well known beyond the region with this surgery?
Yes, I'm past president of the American Hernia Society and travel all over the world routinely for giving lectures on this topic.
Well, I would guess most of our listeners have no idea what abdominal wall reconstruction is and why you would need to have it. So let's start. Why is there a Center for Abdominal Wall Reconstruction?
Well, when you talk about abdominal wall reconstruction, you're talking about defects in the abdominal wall, and most of them are related to hernias. The vast majority are related to hernias, but there can be other reasons why somebody might have a disruption of their abdominal wall. Trauma, they may have been in an accident of some type. And so there are other reasons, and that's why we group all this under the heading of abdominal wall reconstruction. But the vast majority of patients have hernias, and these hernias can be in the groin, they can be in the umbilicus, they can be in old incisions where people have had surgeries before.
Well, the way I think about hernias is whenever someone's lifting something heavy, they'll say, "Oh my gosh, be careful, you're going to give yourself a hernia." Is that just one little itty-bitty kind of hernia? What are some of the other types of hernia?
Lifting has always classically been thought to be important in all hernias, the development of all hernias, but it's being questioned now because we know that people like weightlifters don't get more frequent hernias than anybody else. So that's being questioned. But hernias usually develop in areas where there are natural holes in the abdominal wall. For example, the umbilicus, where the cord structures came through in utero, in the groin, where either the round ligament in a female or the testicular vessels and vas deferens in a male come through, and these are weakened areas.
So the female and the male organs where they hook into the stomach.
Where they come through the abdominal wall.
So it's like a leaky pipe. It's like where the pipes kind of come away, and so a hernia isn't just a hole, or is it a hole?
Basically, it is a hole in the abdominal wall, and what happens is that the lining of the abdominal wall pooches through that hole, and just like an inner tube in a car would do if you had a weak, and that's called the sac because it looks like a sac when it pooches out there. And the problem with that is that things from inside the abdomen can find their way into that sac, and then because of the tight neck of the hole can become obstructed or constricted, and that can go on to gangrene actually of anything that finds its way in. And that's why this abdominal wall construction is included under the umbrella of digestive disease, of the Digestive Disease Center, because it does affect intra-abdominal.
How does one know
organs.
that they have a hernia?
Mostly they see a bulge.
They see it?
They'll see a bulge somewhere in there, wherever the hernia is.
Okay, on a woman, I would guess that it's down in the groin area. That's where
or the umbilicus, if they have an umbilical hernia, or through an old incision. And then these can be painful. Commonly are very painful, and so they have a combination of the bulge and the pain. The diagnosis is pretty secure.
Oh my gosh. So then you go in, and what you do, which is your level of your area of expertise, how do you go repair this?
Well, the field in the last, say, 5 years has become very complex, and that's because of the development of many new prosthetic materials. That means materials used to reconstruct the abdominal wall. In the past, hernias were repaired by simply using sutures and closing the hole.
Uh-huh.
And we know now that that is not very effective, and very, very many of those hernia repairs will ultimately break down.
Because they'll just rip open again.
Yeah. So we have to use some type of artificial substance, either plastic, or now we have what we call the so-called biological prostheses, which are more natural and sort of remold into human tissue. And so the field is, and that's why the need for a center of excellence, because the field has become so complex, even physicians can't keep track of which prosthetic material should be used for which type of problem.
So is it kind of a patch?
It's like a patch.
But it grows like skin.
If you use the biological. If you use the plastic, it's just, the body just grows into it, and it provides a scaffold.
How big is a hernia?
It can be any size. They can be small, size of your thumb. They can be huge. They can be really huge sometimes. I mean,
all right, let's go with that really huge for a minute. What could cause that? Like trauma or?
Usually through incisions. Incisional hernias are the ones that get the biggest, but they can be, I mean, literally wheelbarrow sized.
So, historically, people have just gone to a surgeon to have it repaired, and now your level of expertise basically now incorporates all these prosthetics?
Prosthetic materials, and we at the center will sometimes see patients in consultation with other surgeons just to give them a recommendation about the best way to go about it, and then their own surgeon will actually do the surgery.
So, what's the recovery time for these surgeries? Again,
It's directly
depends on
related
whether
to
it's
the
the
size.
wheelbarrow or
Yeah,
not, I bet you.
it's
Yeah.
directly related to the size. And we have two different approaches. One is conventional surgery, where we make an incision, or we do laparoscopic surgery commonly nowadays, where we just use small little incisions and use a lighted instrument and place the prosthesis inside the abdomen. But then that's, again, it's complex to know which one to use for which particular hernia. It's not always better to use laparoscopy.
Who's more likely to get have your surgery, men or women?
I would say probably men, because groin hernias are so much more common in men than women. And a groin hernia is the most common type of a hernia. But all the other hernias, it would be equal.
What kind of hernias, and I'm going to ask this last question because my own personal reason, why would women develop a hernia?
Any incision, if they've had a hysterectomy through an abdominal incision, they might develop a hernia, or through a C-section. That's quite common. They can also develop groin hernias, just like men can, but they're much less common. And then the incidence of something like a belly button umbilical hernia would be about the same.
And so to know if I had a hernia, I would feel it, I would see it, and I would have pain.
Correct.
And I would go to a primary physician who would then recommend that I come to see you, or would I come? Well, I would guess I'd go to primary because I wouldn't dream that it was a hernia. I'd think it was something else. And in many areas, I would guess it's a relief to find out it is a hernia. It can be so easily repaired.
Yes.
Thank you. And when we come back, we will learn about lifestyle changes that can make a difference.
Meet a doctor with a deeper commitment. Ray Heller is more than a great physician. He's a triathlete, 10 years running. He's a doctor who supports the home team, and he's a dedicated father. Why is that important? Because Ray goes the extra mile. He understands that his commitment reaches beyond his clinic. Because of this, he's a better physician. Creighton Physicians, committed to you and our community.
I'm here with Dr. K. And Dr. K, I'm going to ask you to introduce yourself for us.
I have a very difficult name. My first name is German, my second name is Indian, and my first name is pronounced Birgit, and the last name is Kandala Wala.
And I'm going to call you Dr. K.
That's just fine.
Dr. K, one of the reasons we're talking with you today is that we have learned about some extreme procedures that are required. We've learned about surgeries needed for hernias. We've talked about surgeries for abdominal wall reconstruction, some esophageal surgeries. And a surgery that you are most familiar with is bariatric surgery. So what I'd like to visit with you about today are two things. One is to describe a little bit what your role is with bariatric surgery. But second of all, I would like you to work with me and our listeners as to what are some lifestyle and weight changes we can do to avoid the drastic. But let's first talk a little bit about your role as a bariatric surgeon.
Well, the bariatric surgery is a specialty where the surgeons do different procedures. Right now, it's probably the best resort for people of a certain weight or who have different complications. And bariatric physicians help the bariatric surgeons before surgery to help people lose about 10% of their weight, and following surgery with the complications that usually go on for many, many years. The more drastic the surgery, the more the complications with either protein deficiencies, vitamin deficiencies. And so a new specialty developed to help the surgeons, and we are now called bariatric physicians. They're usually people from internal medicine, pediatrics, family medicine, and we have a board certification. And so I was able to complete that and now have an official designation of being a bariatric physician. We do have about 2 or 3 of them here in Omaha, and we really try to focus on weight.
So the bariatric surgery is when you, we're seeing it on TV like crazy right now, where they put the ring in to stop the stomach from growing. Could you just maybe define real quickly the bariatric surgery process?
There are different degrees of surgery. The lap band is probably the simplest and may not be the most effective for a lot of people who are trying to lose a lot of weight, but it does definitely help. It's a simpler procedure where the surgeon can go in and put a band and then come out. The other ones are a little more complicated and associated with more intensive incisions and malabsorption later on, which is probably the gastric bypass. At the same time, the gastric bypass can cure diabetes, which has been a significant advance because everybody thought once you had diabetes, you would have it for life. But now we're actually finding people can be off their medications, off the insulin about a week after gastric bypass.
Oh my.
And for certain people who are very severely obese, we actually have a little more complicated, a little more malabsorptive surgery where the surgeons rearrange the gut lower down, and it really helps people keep off that 100, 200 pounds that increases the length of their life. Bariatric surgery is now being shown to actually increase mortality.
Really?
About by 10 years, because of the weight in certain people is so pathological. It's as if they were smoking or having some other, something similar to that. And people who require surgery, who are the candidates for this, doesn't mean everybody. But if you are a candidate for surgery and you do undergo surgery in a center of excellence, you can actually regain 10 years of your life.
Well, I noticed that you're holding a body mass index chart. Who are the candidates for bariatric surgery, and help us understand that?
Currently, the cutoff is 40 BMI. Body mass index is a very loose term that that was defined by insurance companies, but helps us come up with a number for weight. And it's really based on your weight and your height, and it is usually your kilograms in your meters, or we can even do it in pounds per inches. And depending on, you can find formulas online in papers or a little sheet like this. The criteria is 35 and above with 2 comorbidities, which is usually diabetes and hypertension.
I see. So not everybody can just go in and say, gee, I want this surgery so I can lose some weight. You have to have several factors.
Yes, you do. You really have to be the right candidate for it. Not everybody who wants to lose 5-10 pounds should go in for bariatric surgery, but in a person who has risk factors, who would definitely benefit from what we call a restrictive procedure, because they've tried everything. They've done diets, they've done exercise, they've done everything. And at a certain stage, and with so much pathology, that they would really benefit from it. So 35 with 2 comorbidities or 40 and above usually qualify. In fact, for most of my patients who have a BMI of over 40, I really encourage them to see if they can get insurance coverage or any funds to maybe look at the surgery, because it can really help their quality of life and help them live longer.
Well, let's then go back to what you were saying. Your role then is to counsel candidates before and after they have their surgery, to help them lose their weight before surgery. And then afterwards, what do you coach them?
Before surgery, we have certain procedures that we have to go through. One is an evaluation, and very importantly, a psychological evaluation.
Really?
Because if the psychology and some of these aspects are not looked at beforehand, surgery is usually not a good resort for certain people.
Because they'll sabotage and gain the weight back up.
Yes.
That's interesting, because I do have a friend that's done that.
Yes. And so we not only look, again, in the holistic idea, you don't only want to look at weight, you also want to look at what are the factors behind that. Will this person be able to make those changes? Or is there some other aspect that needs to be looked into before you go ahead with a procedure that really requires a tremendous amount of commitment? Most people think we'll just go in and have surgery and, life is great and I'll just lose all this weight. The hard work begins afterwards.
And what is that?
Really watching what you're eating and increasing your activity. The eating habits, staying away from binging, having regular meals at regular times probably is something that has to be learned and gone over and over. As we know, you have to repeat something 27 times before it becomes a habit. So unless the old habits are modified and changed, you're not going to be having as much success later on.
And we can come back to this if we have time, but I guess I want to talk a little bit about the real life people that are out there listening to our shows that want to avoid the drastic measures. What are the and I'm making this probably overly simple, but what are 5 things that just normal people can do to avoid the reflux and the abdominal wall surgeries and so forth?
The one thing that most of my patients are disappointed when I say this, my first point is, can we just maintain your weight?
Maintain it.
Can we just maintain, not lose?
Maintain.
Maintaining one's weight is a full-time job. And I know nobody wants to hear it because they're like, oh, I want to lose 100 pounds. Let's first maintain weight. Usually there's a weight gain over the winter months or, those 15, 20 pounds that
every decade.
Every decade.
Yeah.
And so the first thing or the first aspect that I talk with any of my patients would be, let's maintain your weight. If you do have weight and you're struggling with a little extra, can you be more physically active? Not necessarily exercise. You don't have to be sweating to have the benefit, but are you physically active? There's more and more data now to suggest that people, even if they have a higher BMI, but they're physically active, can offset some of the negative aspects of having particularly the fat around the abdomen. Third, if you do want to lose weight, how about we focus on 5 or 10%? Most people will come in, I want to lose 100 pounds and I want to be 120 pounds and go on that cruise. And usually it's a little disappointing when I put down 5% as the first goal. Can we work on maintaining 5% weight loss? Everybody can lose weight one way or the other. What is it that keeps it off? And then it comes to the third part, which is self-monitoring. When we self-monitor, we're usually able to keep the weight off. I'm not so interested in how do we lose weight. I'm really more interested in how do we prevent those pounds from coming back. Because our bodies, the biology of our bodies, unfortunately, the default setting in our bodies is to regain that weight. And that's what happened with Oprah. And I always mention Oprah because she regained all her weight, even with everything around her. Self-monitoring, weighing yourself regularly, probably, which was what Weight Watchers do, is something I encourage highly in all my patients. After that, I would, as I've said, 5 to 10% weight loss. By the diabetes prevention study showed that even if you can keep that 5 to 10% off, your comorbidities improve 50%. 10% weight loss, 50% benefit. So you really don't have to lose humongous amounts of weight, little bits, but keeping them off. And lastly, sticking with a lifestyle routine that works for you. If you jump off and change everything in your life, it's probably not going to work. But if there are friends that can help you with, support that you can have, that you incorporate little bits of physical activity and good nutrition throughout, you probably can maintain your weight and maybe lose 5 to 10%.
Thank you. Move more, eat less, take care of yourself. Thank you for joining us today at the Center for Digestive Disorders. On behalf of all of us at Creighton, thanks for watching.